Drinking is one of the very first activities that newborns engage in, not only shaping their daily routine, but also fostering crucial communication and interaction between them and their caregivers. Developing skills such as sucking and swallowing and coordinating these with breathing is vital, but what happens when a baby struggles with these essential tasks? We were thrilled to speak with Professor Joan Arvedson from the Medical College of Wisconsin, a leading expert in pediatric feeding and swallowing disorders. In our conversation, she explains the intricacies of sensorimotor learning, neuroplasticity, and the developmental processes underlying sucking and swallowing in infants. We also talk about some fundamental principles that we as clinicians should consider, principles that apply not just to the pediatric population, but to adults as well, making this episode valuable for anyone in the field. Hello, Joan, and welcome to the Dysphagia Matters podcast. We're really happy to have you with us today.
It is a privilege for me, and thank you for inviting me.
So to begin with, could you provide an overview of how sucking and swallowing develop during pregnancy?
Well, we could take 3 hours to do that, and we won't do that in all of that detail. But probably for these purposes, we know there is an enormous amount of development in the head and neck in the first 8 weeks, the embryologic portion of a pregnancy. We know that the palate is completed by about 12 weeks. So that means from lip to hard palate to soft palate. And we have seen that a pharyngeal swallow, not necessarily sucking pattern observed in ultrasound, these are findings from ultrasound, has been noted as early as about 10 to 12 weeks gestation. So very early in gestation, the infants are swallowing, and they are swallowing amniotic fluid. So we have to remember the environment in which this fetus, which is the technical term for the in utero baby, is. True sucking, and some people make a big distinction about suckling as the earliest pattern in English, and then sucking. Some of the literature will use sucking all the way through, and I don't believe it's really clearly distinguished. So I will probably say sucking most of what we're talking about, but I do want people to be aware that very early suckling may be the term. So that's noted by about 18 to 24 weeks. Now think about the earliest that an infant is born and survives. That's probably about, things like the timing works lower and lower with our very sophisticated interventions that can help to save very young infants. But seems like it's now, could be as young as 22 weeks, but 23 to 24 weeks. And that's when we see real sucking. So in that 18 to 24 weeks, we do see sucking patterns. And then we don't expect infants to be able to take enough liquid at the breast or at a bottle to sustain nutrition until probably 34 to 37 weeks. And now the most rapidly increasing group of preterm infants is what we call late preterm. And you're probably familiar with that. So from about 36 weeks, it differs some in the literature. So you just have to really, when people look at the literature, they really need to look at the number of weeks and not just the term that's used for that. And then what are the other conditions that go along with that, not just the timing of the birth. But that's where we expect them to be able to coordinate, suck, swallow, and breathe. And we have to always remember, nutrition is absolutely critical, and that means nutrition and hydration. So I always say, as they get a little bit older and they're doing a little more feeding as well, every time we think nutrition, and we have to know a lot about nutrition, but as speech pathologists, speech therapists, I'll probably end up saying speech pathologists just because that's what I'm more used to saying, and others just take that with a grain of salt, so to speak, that we have to know a whole lot about these things, but we don't make decisions about what people should do with nutrition. So sucking and swallowing, critical, and airway. You have to have a stable airway in order to feed orally, and that holds across the lifespan. So airway always takes precedence. You have to be able to breathe easily. And what do infants have to do from the very beginning? They have to be nose breathers, because in order to maintain a latch at the breast or a bottle, they have to breathe through their nose, right? So when there are conditions that affect the upper airway, choanal atresia would be an extreme, and I won't go into some of the other possibilities, then that has to take precedence. So thank heavens we do have alternate ways to help babies and children get their nutrition with some kind of tube feeding. And I would just say right at this point, I think it's important to think about tubes, whatever type they are, as a tool. I don't really like the word tool, but in this instance, I think it's probably okay that tubes can go in and tubes can come out. And they are not a last resort. They are not a sign of failure. It is a sign of what can we do to help overall health, stability, well-being, and not have too much pressure about the feeding.
Yeah, I was just wondering again about the key milestone. So you said the swallowing itself needs to be established or developed. Of course, the airway protection, that there are nose breathers, so that it's possible to suck via mouth and breathe via nose. Did I forget about anything?
Well, we have to also know that the gastrointestinal tract is functioning appropriately and adequately, because as you know, there are some conditions, tracheoesophageal fistula, esophageal atresia, in which even if somebody can suck and swallow, it's not going to go where it's supposed to go. So we have to think about all of the systems, and they are very much interrelated. And what is it that is central to all of these things when we think about feeding and swallowing? It is the brain. It's the central nervous system. So I will often, when I think about feeding and swallowing, I will emphasize the airway. I'll also sometimes kind of make it a triangle. The airway, the gastrointestinal tract, and then feeding and swallowing. And I distinguish, well, maybe it's not even distinguished, but take into account all of these babies and children, because we're going to talk about children as they get just a little bit beyond this point, have feeding problems, but they do not all have dysphagia. And by definition, dysphagia simply means a swallowing problem. So the feeding disorder, which we now do have defined in better ways for descriptive purposes about billing in some countries and about intervention purposes, etc. And I think those are important things to consider as well. So I'd urge people to look at the article by Praveen Godet and quite a group of people as they defined pediatric feeding disorder. Right now, I think we're talking more about the swallowing problems. And we have defined them in the past. We've talked about oral phase, pharyngeal phase, esophageal phase. But what we have learned in recent years, and this crosses the age spectrum too, and maybe others have already talked about this, there is overlapping. They interrelate. So rather than talking about oral phase or stage, we can talk about preparing a bolus, oral function, pharyngeal function, oropharyngeal function, and then as it also directly relates to upper esophageal sphincter function and esophageal. So it's really extraordinarily complex. And I think people who try to simplify and just do some kind of a program to help somebody suck more efficiently or chew more efficiently, they just really miss the boat. And I will also emphasize right now, because I think it plays into whatever else we think about. It's very important to get to the underlying etiology, at least as close as possible. It's not always possible to define a true cause or etiology. But if we don't really get to what's underlying these swallowing, feeding problems, then we're treating signs and symptoms, and that's not very effective. I'm also a fussy person about terminology. So I think it's really important that we keep working toward defining our terms so that when I use a term, you know exactly what I'm describing. Now, how often do you hear signs and symptoms being used interchangeably?
All the time, all the time.
Yes. And what is a sign? A sign is something that can be observed. What is a symptom? If we can tell our own doctors or somebody else, it's what we are aware of as an individual. So if I have esophagitis, I can explain it really hurts every time I eat, yada, da, da, da. But what is it about our babies or the older children who don't talk? At least most of the ones I see have delays or difficulties about their communication as well. So we have to infer the symptoms from the signs. So when children are fussing and crying, why are they doing that? Maybe they really have pains in their esophagus or somewhere else in their body, or we are pushing too hard. And then what do we do if we push too hard? We end up with fussy eaters, picky eaters, aversive feeding. And I believe that for the most part, we impose that aversion from the outside. Or it may also be, when we think about some of these very young infants where we started this conversation, that they have gone through intubation, they have been suctioned, they may have had surgery procedures, cardiac surgery, or they have major pulmonary problems. They have had a lot of aversive experiences, very stressful kinds of processes or procedures done to them or for them, which are absolutely critical to sustain life. But once things are more stable with these babies, the literature is not super clear about this. But if we really look at the underlying sensory, motor, neurophysiology aspects of this development, is that we believe that these babies have very strong memories of those very negative experiences. So when everything is okay, and now the child should be able to just sort of eat and drink and grow and make developmental gains, that may not be the case. And if we push too hard too fast, then we end up imposing a feeding disorder.
Mm-hmm. And we have a whole lot of new problems just emerging by that.
Yeah.
Can I ask one question? It's it was in the very beginning, but I just took a note and I wanted to pick up on that again, if that's okay.
Sure.
You said that nowadays with the medical technology and everything, babies are able to survive from 22 to 24 weeks. Is that right?
Yes, at least a proportion of them.
Yeah, okay. And so then you said like a sufficient feed is possible around 34 weeks so that they really get all the nutrition and hydration they need. Does this mean that usually, maybe not, we can't speak for all, but the majority of babies need a feeding tube or some additional feeding if they are born between 24 to 34 weeks?
Yes. Yes. I
Okay.
think it would be highly unusual that a baby born at 24 to 29, 30 weeks even would be able to be an oral feeder. Now, when do we start facilitating some of that feeding? If you are working in a NICU or in an environment where these very young infants are there, hopefully their mothers or primary caregivers are with them essentially all the time, because we do know that consistency of primary caregivers is very important, and that differs a lot in different cultures, different facilities, but that primary caregiver is really important. Now, we know that infants are sucking, but they're doing sucking that's primarily non-nutritive. Could be on a pacifier, dummy, different terms for those artificial nipples. It could be on their fingers. Some of them get their fingers to their mouths.
Or their whole hand.
Yes, or their whole hand, so that they are doing that sucking. Now, it's also important for us to remember that non-nutritive sucking is at a rate of about 2 sucks per second. Nutritive sucking, meaning when you got some liquid to swallow, is at 1 suck per second. So the non-nutritive is faster because they don't have to coordinate that suck, swallow, and breathe in the same way as if they are taking in liquid. So that's an easier process. And some of them, if they have a intubation tube even, they suck kind of on that tube. People who may be listening to this and have also been in those environments, we can see them sucking on those tubes. So they're doing that non-nutritive sucking, but it does not necessarily translate to suck, swallow, breathe in a functional way to take sufficient volume for them to gain weight and grow. So I describe that as non-nutritive sucking is a necessary but not sufficient skill for oral feeding. Does that make sense as well? But if the infant isn't even doing that non-nutritive sucking, how could we expect them to coordinate suck and swallow and breathe? So again, when we think about what kind of guidance do we give as therapists to nurses, and many nurses are very highly skilled with this, but there are a lot of different kind of approaches. And then how do we help the parents with that too? I have a wonderful photo. I don't even know where I got it. It's of in utero at about 6 months, 24 weeks. And you can see, because they're very well formed, when they're born, everything looks very normal. And here's this infant with the thumb right up here in very flexed position because it's taken up most of the room in utero. And what is he doing? He's doing non-nutritive sucking. And he's doing some swallowing because there is amniotic fluid. And we have saliva, all of us, so that if somebody's sucking, they're still going to swallow once in a while. And I'm thinking, that's what we want to simulate when these babies do get delivered early. And that's where OTs, occupational therapists, physiotherapists, developmental specialists, and we really think about a very coordinated developmental care in the neonatal intensive care unit. And there is an excellent website, and have been a part of an international consensus panel working to improve or get more consistent with the NICU environment overall. And that could be a whole different talk as well. And if it might be useful for you all to add that website.
Yes, absolutely. We'll add it to the show notes of this episode.
Okay.
Got one more question about the non-nutritive sucking. So is it like that it's kind of a stage prior to the nutritive sucking? So is it first non-nutritive, then from that it develops the nutritive sucking? And do you think that nutritive sucking then can also be trained by non-nutritive sucking? Because in the literature, there are some voices who say that it's not the same, because the let's say the magic behind it is the breathing coordination next to swallowing and sucking. But do you think that we can use the non-nutritive sucking as a way to train the nutritive sucking as well?
Yes. I do not use the word train. So I'm going to talk about that just for a minute as well. But I think what we are doing is to facilitate, and maybe it's just a slightly different wording, but I think that baby figures it out, but we have to help to facilitate, in a sense, to set the stage for that. And if we think about the advancing to nipple feeding, and I'm sure there are exceptions, so whatever we say isn't going to hold for all babies or in all circumstances. But very often these infants will be sucking either on their own fingers or an intubation tube, or sometimes just kind of on their tongue. You can just see them. And you can say, I think that baby's just really sucking. But when they're very, very little, there are some very small, short, and fairly narrow diameter pacifiers that are available in NICUs. But as the baby grows and gets closer to true breastfeeding or bottle feeding, then you want to have a pacifier that gets closer to the size and shape of the nipple that you're going to be using. And probably it's a little bit more straightforward if you're thinking about it for bottle feeding rather than breastfeeding. But there are more similarities than there are differences. And I work with lactation consultants on the outpatient side, and we see some very young infants. Now, they work on the inpatient side with speech pathologists and lactation consultants. So most of the moms that we find, and I'm using the term mom, but I mean anybody who's the primary caregiver, and I think we want to make that very clear in this day and age as well. But if I use the word mom, that mother, that just means the closest one at this point, whoever it is, would be, now I lost my train of thought, for looking toward breastfeeding. But many of them, at least in the United States, they have to go back to work within a few months too. So they really need a combination of breastfeeding and bottle feeding. And they can actually help facilitate one or the other. I will say that those bottle systems that are advertised as being like a mother's breast, none of them really are. So it's not like there's just one. And there's so many things on the market nowadays that I think are just as overwhelming to people. And we won't go into that sort of thing. But you want to help an infant get whatever the nipple is. You touch it to the lower lip, ease it in as the infant starts sucking, and you want it in as deep as possible. That's not stressful to the baby. That's why some of those little short nipples aren't really helpful, so that they can get the stripping action that they need. And one of the very basic things that I think not everybody pays attention to is that the lips need to be flared out. There's some sensory nerve endings on the inside, the upper lip particularly, called the pars villi. I always tell parents you don't need to remember that. But it isn't just about motor coordination. It's about the sensory aspect as well. So we can't think sensory or motor. We have to think sensory motor. And some of the work that I've done as well as some other people in the first couple of editions of Pediatric Swallowing and Feeding, we talked about sensory and we talked about motor. Then I, as a generic term, put it as one word. So in English, it's sensorimotor, because we always have to be thinking, whether it's smell, taste, feel, goes right along with what we're doing in any kind of a motor planning way. So flared lips touching the rim of the bottle cap or as deep into the mom's breast as possible that makes sense. Then they're more efficient with their sucking, their swallowing, and their breathing pattern. And people think you got to interrupt them to burp after they've had a little bit. What does that do? All that does is interrupt, and either they think they're done or they get really fussy. And then they take in air probably, and they don't even really, if you just let them keep going, if they're well coordinated, they don't need to burp. Burping is overrated. That's an Arvedson term. So be careful.
I like
That's a statement.
I like that.
And sometimes parents will say, when I say, does he pass gas? And sometimes I just say, does she fart? And yeah, lots, little tiny babies. I said, well, that's where, if they've got bubble into their GI tract, that's another way of releasing the so-called air. We don't know exactly what's happening, but that would be a logical inference. So if they can do it that way, why should we be getting them up and whacking them on the back? Sometimes that just makes it worse. So you want to keep the pressure off of their abdomen, the end of the feed, tilting back slightly. And we think that that helps to, gravity help to keep the liquid down. And now we won't go into thickening or not thickening for these purposes. Is that okay?
Yes, that's a whole other episode.
Yeah.
Can I maybe ask you, because I really like your way of approaching or saying that terminology is important. So why do you think we shouldn't say train to train babies?
I don't know how to train babies. I don't know how to train anybody. So what do we mean by train? I'm not sure we even teach. Some people use the term teach children to chew or teach children to get lip closure around a spoon. I'll just go to a little bit older children rather than the tiny infants. But when I think about seeing an infant or seeing a child, I think, what is it that this child does? And then what would be the next logical step developmentally that we want to help that child achieve? How do we do that? We have to watch, listen, analyze, but we don't have just simple checklists. There are a few checklists out there that can be helpful. I'm not going to go into any specific kind of checklist or standardized way of looking at things, because I think that they may be helpful, but they also all have problems. So what is it that, where is this child developmentally? So the child might be 14 months old chronologic, but would be 10 months old corrected, but he's not sitting independently. He's not rolling over. Head control is still variable. So where is that child developmentally in kind of a broad sense? Less than 6 months. So would that child be expected to sit in a high chair and do spoon feeding? No. And maybe they're very low tone, so the mouth is open. There may be some drooling as well. They may not be aware of the saliva in their mouth, or there may be hypertonicity, so they may be spastic. And then we have to think about, okay, what can they do? And then what are they doing right now? And then what would be the next logical step? And sometimes parents will say, he won't accept anything. He won't accept a spoon. Well, how do people try to start with that spoon? They put a glob of puree on it and expect the kid to accept it in the mouth and swallow it. No, you got to see if they'll accept it to touch it to the lip. A dry spoon, perhaps. And then onto the tongue. And then maybe with just a drop of water, less than their own saliva. Maybe they could aspirate, but not going to hurt them. You've got saliva, and if you're not managing your saliva, remember the mouth is filled with bacteria. So I'm kind of jumping all over the place maybe, but if that lets people think a little bit more, oh, yeah, now I remember seeing this kid in blah, 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 you know. So you figure out where the child is in the broad sense and in the oral sense. And then what would be the next logical developmentally appropriate? And it usually has to go very slow and gradual. And I'll tell parents, the most basic thing is acceptance without stress. And that goes from the NICU all the way wherever.
You say basic, but I can imagine that is really difficult.
Yes, yes, because people are so anxious to
Mm-hmm.
get this child to do something. But if we do things in a way that are stressful, then it's just going to take longer and will be more difficult. I often use the analogy, and I'm amazed at how many parents, grandparents, whoever, from varied cultures, varied age ranges, who actually do have some reference to the Aesop's fable, The Hare and the Tortoise. Sometimes I have to say, did you ever hear that story about the race between the rabbit and the turtle? Oh, yes. Who won that race? Yeah, the turtle. Why did the turtle win that race? Slow, steady, straightforward, purposeful. It is amazing. So slow is tough for parents, and I think for many therapists to deal with as well.
Yes, absolutely.
That's true.
Yeah. And the rabbit is running fast, but in a zigzag.
Hippity hop all over the place. If this doesn't work, well, then let's try that. If this doesn't work, then let's get the nook brush, and maybe if we just dip the nook brush in and let them. No. It doesn't mean you shouldn't ever use it. I'm not saying that, but you have to just be very cautious. And it holds from the NICU all the way through, regardless of the underlying etiologies, because then we have to take into account what we predict might happen with a child, so that there are some children that may need a feeding tube for a while, but on the basis of their underlying diagnosis, you would expect that after a few more months, they're really going to be able to do oral feeding. Prader-Willi is an example of that. Often those babies are very low tone early in their lives, but they're going to become what we call hyperphagic. And the refrigerator has to be locked because they're after food. So you can do a little bit of predicting, but more children, I will tell parents, this is what we know at this time, but you know your child has every chance to beat the odds. So you give people hope, but not false hope, and keep emphasizing those small steps, not stressful, functional, but that's what takes so much thinking and underlying knowledge, why I'm always looking at the literature in all of these areas. What else? Those are my two favorite four-letter words in English. What else do I need to think about? Might be going on. And if we're always asking those questions and helping parents and others as well. And I think that even if we are working in kind of isolated ways, somehow there's some sort of a team. People who do home care, for instance, birth to 3, we talk about at home care in the United States. It may differ in some other countries, but nobody can work in isolation. So when I'm going to see somebody, and I know that a speech pathologist is seeing that infant or that child in home therapy or in some other kind of a program, I want to know what that person is seeing. And because they may be seeing them probably more often than I am. And if we're going to do some kind of a test, like a video swallow study in radiology, if that person can come with the family, that is of enormous help, because then they're the ones who are helping. But remember, we saw this.
Mm-hmm.
And so it takes a team. It's always a team of some sort or another, but they can be very, very different.
Yeah, and especially with the instrumental assessment, and this is probably true for all ages again, it's only such a short time period that we are looking at. And so it's really important to get the knowledge, experiences, perspectives from what is happening outside of those 5 minutes, 2 minutes, 1 minute, maybe maximum.
Yeah.
Depending if you're doing FEES or video fluoroscopy.
And reminding people about the purpose. The purpose is to determine the strength and the timing coordination, especially of the area that we can't observe, because I can only infer pharyngeal function by watching somebody clinically. So whether it's FEES or video fluoroscopy, and it is a very small window in time in an atypical situation, but it can give us some information about strength and timing. It certainly doesn't tell us whether they aspirate it sometimes, because we all do. And I think it's really important that we stress to people that it's not pass or fail, either one. And I still hear that. I'll hear that from physicians, and I'll hear it from parents. He failed or he passed. It's not pass or fail. It describes something about sensorimotor function. And I think that's a very important job that we have as part of what we do as professionals in working with children and families with dysphagia, with feeding disorders.
That wraps up the first part of our conversation with Professor Joan Arvedson. We've covered some fascinating ground so far, but there's so much more to explore. In the next episode, we'll talk about the treatment of feeding and swallowing disorders in infants and children, discussing not only the techniques and approaches, but also the crucial role that parents play in this process. Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram @DysphagiaMatters, on Twitter @DysphagiaPcast, or visit our website at dysphagiamatters.org. Take care, everyone.